Hello once again, this is your professor, Dr. Benjamir Cabrera, and I'll be giving the part 3 of the 3-part lecture on clinical therapeutics of antimicrobial for pharmacology 2. So we will be covering antihelminthics, antifungals, and the drugs for COVID-19. So it is a little bit shorter than the part 2. So antihelminthics. So hopefully you are aware of this guy. This is Ascaris lumbricoides, the most common intestinal parasite in children. Okay, so this is what we call the spaghetti or roundworm. So the drugs that act against nematodes, we have a lot of drugs. First would be albendazole. It acts by inhibiting the microtubule assembly. This is the primary drug for use for cases of ascariasis, tapeworm infestation, capillariasis, hookworm, pinworm, and whipworm. Though it has few toxic effects during short course of therapy, it is usually used for this 1 to 3 days therapy. It can be given on a single dose or given at a twice a day dose for 3 days. For adult dose, a single dose of 400 milligrams per day. But for pediatrics, you can give it at 15 milligrams per kilo per day, maximum of 400 milligrams per day. Next would be your diethylcarbamazine. It acts by immobilizing microfilariae by an unknown mechanism. This is the drug of choice for several filarial infections, and reactions to protein released by dying filariae will include fever, rashes, ocular damage, joint and muscle pain, and lymphangitis. The third would be your ivermectin. This is the drug that has been on the spot during the COVID-19. Okay. The real use for ivermectin is it intensifies the gamma aminobutyric acid mediated neurotransmitter neurotransmission in nematodes and causes immobilization of the parasite. For such cases, it does not cross the blood-brain barrier. It is the drug of choice for onchocerciasis, cutaneous larva migrans, strongyloidiasis, and some forms of filariasis. So it's also used for our pets, for our dogos. Okay, so we use it to control ticks and fleas. Okay, but you should always be careful for its toxicity. The fourth would be your mebendazole. Another after albendazole would be your mebendazole. Just like your albendazole, it selectively inhibits microtubule synthesis and glucose uptake in nematodes. It is also the primary drug for treatment of ascariasis and pinworm and whipworm infections. So your pinworm are the ones that causes pruritus ani, nocturnal pruritus ani, wherein the mother worm will go out on the perianal area to lay its egg. Okay, and the eggs would be so light that it can be sniffed. So the life cycle that from the egg, okay, from the perianal area, it dislodges. So some will go to the underwear when you try to before laundry. Some of us will try to shake it off, and because these eggs are very light, so they tend to be inhaled and goes to our, and some can be swallowed. So that's the life cycle of Enterobius vermicularis. And then the fifth would be your piperazine. It is an agonist at the GABA receptors. It causes paralysis of roundworms and then later on are expelled, okay, by normal peristalsis. The next medicine will be your thiabendazole. It is a structural congener of mebendazole. It has a similar action on microtubules, but thiabendazole is much more toxic than other benzimidazole or ivermectin. And it also causes reactions by dying parasites will manifest as fever, okay, chills, lymphadenopathy, and a rash. Next will be your pyrantel pamoate. Okay. It stimulates nicotinic receptor present at the neuromuscular junction of nematodes. It causes contraction of muscles followed by depolarization, inducing paralysis. And for the trematodes or the flukes, we have the following uh, medications. First would be your praziquantel. It increases membrane permeability to calcium, causing marked contraction initially, then paralysis. This is the drug of choice for schistosomiasis of all the species of it, for clonorchiasis and paragomeniasis, and for infections caused by small and large intestinal flukes. The second will be your bithionol. It's a co-drug of choice used with triclabendazole for the treatment of fascioliasis or sheep liver fluke and an alternative agent in paragomiasis. Mechanism of action is still unknown. Then the third would be your metryptonate. Okay, it is an organophosphate prodrug that is converted into the body with the cholinesterase inhibitor dichlorvos, solely used against Schistosoma hematobium. Okay. It is the one that dislodges on the biliary tree, causing bilharziosis. The fourth will be your oxamnikin. Okay, it's solely used also for Schistosoma mansoni. It causes paralysis of the worms, but its precise mechanism is still yet to be found. Then next for the next drugs that we'll be discussing would be, so we will be covering antihelminthics, antifungals, and the drugs for COVID-19. So it is a little bit shorter than the part 2, the antifungals. So the antifungal agents, so this is a case of an, what we call in our dialect, okay, or tinea corporis. Okay. We have a lot of drugs. First would be your amphotericin B. So the drugs used for systemic fungal infections would be your amphotericin B. It is a polyene related to nystatin. It is poorly absorbed by GI. Thus, it is given as an intravenous non-lipid colloidal suspension, lipid complex, or liposomal formulation. It is widely distributed systemically, but it does not cross the blood-brain barrier, so it cannot penetrate the central nervous system. Elimination is via the hepatic metabolism, okay, and with a half-life of around 2 weeks. For amphotericin B, this is a non-dialyzable drug. So mechanism of action of amphotericin B is that the polyenes are molecules that are both hydrophilic, means it loves water, and lipophilic, also it loves fats. Okay, it binds to ergosterol, which are steroids specific to fungal membranes, and cause pores on those membranes. Resistance is via decreased level or a structural change of ergosterol. So where do we use amphotericin B or the polyenes? It is the widest antifungal spectrum of any agent. This is the drug of choice or co-drug of choice for most systemic infection caused by Aspergillus, Blastomyces, Candida albicans, Cryptococcus, Histoplasma, and Mucormycosis. Toxicity, it is infusion related, thus it may cause as adverse events would be your fever, chills, muscle spasms, vomiting, shock-like fall in blood pressure, attenuated by slow infusion rate and by pre-medication with antihistamines, antipyretics, heparidine, or glucocorticoids. Those limiting scenarios, it decreases the glomerular filtration rate and causes renal tubular acidosis with magnesium and potassium wasting. Also, for anemia from decreased renal formation of erythropoietin, so those are we have to consider. And liposomal formulations of amphotericin B reduce nephrotoxic effects, okay, due to decreased binding to renal cells. It also has neurotoxic effects. Thus, intrathecal administration may cause seizure and neurologic damage. The next systemic antifungal would be your flucytosine or your 5-fluorocytosine or 5-FC. This is a pyrimidine antimetabolite related to the anti-cancer 5-fluorouracil. It is effective orally, distributed to most tissues, including the central nervous system. Eliminated intact in the urine and must be reduced for patients with renal problems. So it acts by the drug will accumulate in the fungal cells through actions of membrane permease and converted by cytosine deaminase to 5-fluorouracil, an inhibitor of thymidylate synthetase. Resistance occurs rapidly if used alone and involves decreased activity of permeases or deaminases. So where do we use this drug? It is limited to the treatment of Cryptococcus neoformans, systemic candidal infections, and chromoblastomycosis by moles. Toxicity, it causes reversible bone marrow depression, alopecia, and liver dysfunction. The third would be the azo antifungal agents. The azo antifungal agents are your ketoconazole, fluconazole, itraconazole, and voriconazole. Oral bioavailability of the azole antifungal agents requires normal gastric acidity. All except fluconazole, okay, doesn't distribute well in the central nervous system, thus their drug levels are achieved very low. Liver metabolism is responsible for the elimination of ketoconazole, itraconazole, and voriconazole. Fluconazole is eliminated by the kidneys or via the renal route, mostly unchanged. Mechanism of action of the azole groups would be it interferes with the membrane permeability by inhibiting the synthesis of ergosterol. It's an act at the step of the 14-alpha demethylation of the lanosterol catalyzed by fungal cytochrome P450 isozyme. Resistance is developed via the changes in sensitivity of the target enzymes. So where do we use it? For ketoconazole, it is not available in parenteral form, but there's available for oral. So it is used for and even topical. It is used for chronic mucocutaneous candidiasis and dermatophytes. For fluconazole, it is the drug of choice in esophageal and oropharyngeal candidiasis, and for most infections caused by coccidioides. Treatment and secondary prophylaxis against cryptococcal meningitis, and the alternative drug of choice in the treatment of Cryptococcus neoformans. A single oral dose eradicates most vaginal candidiasis, and the effect of fluconazole is equivalent to amphotericin B in candidemia. Then we have your itraconazole. It is a drug of choice for blastomyces, sporotrix, and chromoblastosis, mycosis. It's an alternative for the treatment of Aspergillus, coccidioides, Cryptococcus, and Histoplasma. It is active against some strains resistant to fluconazole. It is extensively used in the treatment of dermatophytes, especially onychomycosis or the fungal infection of the nails. Then we have the voriconazole. It is a co-drug of choice for the treatment of invasive aspergillosis. It's used as an alternative drug in candidemia with activity against some fluconazole-resistant organisms and in AIDS or acquired immune deficiency syndrome patients that has been used in the treatment of candidial esophagitis and stomatitis. Another antifungal drug would be your posaconazole. It is the broadest spectrum triazole, only azole with activity against rhizopus, an agent of mucormycosis. It is used as a prophylaxis treatment of fungal infections during cancer chemotherapy. It's also used as a drug used for the salvage therapy in invasive aspergillosis. Toxicity of such drug will manifest as vomiting, diarrhea, rash, and sometimes hepatotoxicity. It is noteworthy to remember that ketoconazole is a notorious inhibitor of the cytochrome P450. Thus, it interferes with the synthesis of the adrenal gonadal steroids and may lead to gynecomastia, menstrual irregularities, and infertility. Other azoles are more selective inhibitors of the fungal cytochrome P450. Voriconazole has an immediate but transient visual effect disturbance. Then we'll now discuss the echinocandins. The echinocandins like your caspofungin, anidulafungin, and micafungin. So these are not quite common drugs. So these are given via intravenous route. It has a wide systemic tissue distribution and eliminated via the hepatic metabolism. Mode of actions of echinocandins inhibits the beta-1,2 glycan, which is a very important component of the fungal cell wall. So clinical uses would be caspofungin is used for the disseminated and mucocutaneous candida infections in patients who fail to respond to amphotericin B and mucormycosis. Anidulafungin is used for esophageal and invasive candidiasis. Micafungin is used for mucocutaneous candidiasis and the drug for prophylaxis of candida infections in patients having bone marrow transplantation. Toxicity for caspofungin, it manifests as headache, gastrointestinal distress, fever, rash, and flushing due to the histamine release. Micafungin manifests histamine release, so there is flushing also, elevated blood levels of the immunosuppressant drugs cyclosporine and sirolimus. Then again, systemic drugs for superficial fungal infection. So it can be superficial, but it can be widespread. So then we can give systemic antifungals. So we can use crisofulvin. It has a good oral absorption, especially if it is aided by high fat food. It is distributed to the stratum corneum of the skin where it binds to keratin. Okay. And it uses the biliary excretion for elimination. It acts by interfering with the microtubule function in dermatophytes. It inhibits synthesis and polymerization of nucleic acids. Resistance is via decreased energy-dependent transport. Okay. In general, crisofulvin is labeled as a fungistatic drug. Uses of crisofulvin is it is not active topically, so it is better given orally. Adverse effect would be headache, mental confusion, GI irritation, photosensitivity, changes in liver function. Crisofulvin is contraindicated in patients with porphyria and those who are taking warfarin as a blood thinner, or it interacts, okay, with warfarin by decreasing the warfarin's bioavailability, resulting in decreased anticoagulant effect. Okay, it also has a disulfiram-like reaction if taken with alcohol. Then next would be your terbinafine. So it acts by inhibiting the squalene epoxidase. The accumulation of squalene interferes with ergosterol synthesis. Thus, terbinafine is labeled as a fungicidal drug. It is used for oral and topical. The drug accumulates in keratin, but it is more effective than crisofulvin in the management of onychomycosis. Adverse effect would be GI upset, rash, headache, and taste disturbance. Now we will be talking on the topical drugs for superficial fungal infection. Okay, so first on the line will be your nystatin. It's a polyene antibiotic and it acts by binding to ergosterol. Topical, and it is used as a topical drug because it is noted to be very toxic if used systemically. Okay? It is used to suppress local candida infections. We can use nystatin orally to eradicate gastrointestinal fungi in patients with impaired defense mechanism. Other topical antifungal agents would be your miconazole and clotrimazole. So we will be covering antihelminthics, antifungals, and the drugs for COVID-19. So it is a little bit shorter than the part 2. Next, we would be tackling about though I know it's quite late now, so now we will be talking about the drugs used during the COVID-19 pandemic. So COVID-19 treatments and medication, it is usually the treatment guidelines coming from the Center for Disease Control. It is updated last year on February 10, 2023. There are 3 antivirals, okay, approved and recommended for outpatient care. The 3 drugs are nirmatrelvir with ritonavir, branded as Paxlovid. Remdesivir, it is sold as Veklury, and Molnupiravir, or the Lagevrio. So this is a table, okay, on the drug and the cases that can that we can give the population of patients when to in this column, when do we use it and how do we use it. So for nirmatrelvir with ritonavir or Paxlovid, it is given for adults and children 12 years and above. We use it as soon as possible and must begin within 5 days when the symptoms start, and it can be taken at home, okay, already. Then remdesivir or Veklury is given for both adults and children. Again, you can start as soon as possible and must begin within 7 days when the symptoms start. Can be given intravenously at the healthcare facility for 3 consecutive days. Then the last would be your molnupiravir or Lagevrio. It's given for adult. You can start as soon as possible but must begin within 5 days when the symptoms start, and it can be taken at home. So let us discuss each one in detail. So nirmatrelvir with ritonavir or Paxlovid is manufactured by Pfizer. EUA by the US FDA was approved, okay, last January of 2022. It is for oral medication, still an investigational medicine. It is used to treat children and adults and children 12 years and above, or older at least with a weight of 40 kilograms, with the diagnosis of mild to moderate COVID-19 infections, and who are at risk for progression to severe COVID-19, including hospitalization or death. Limited information about the safety and effectiveness using Paxlovid to treat people with mild to moderate COVID. Nirmatrelvir is a peptidomimetic inhibitor of the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 main protease, while the additional drug, the ritonavir, is used for the HIV-1 protease inhibitor and CYP3A inhibitor. Then the second drug would be your remdesivir or Veklury. It is manufactured by Gilead Sciences. This is the first drug approved by the Food and Drug Administration for Compassionate Special Permit or CSP. It is an intravenous antiviral agent. It is used for the treatment of COVID-19 disease in hospitalized adults and children 12 and above who are weighing at least 40 kilograms. It is a broad-spectrum antiviral in a nucleotide analog prodrug. US FDA issued the emergency use authorization on May 1 of 2020 to allow remdesivir for severe COVID-19, okay, either confirmed or suspected in hospitalized adults and children. The third will be your molnupiravir. It is manufactured by Merck and Ridgeback by Therapeutics. It is the newer antiviral drug that has recently received the emergency use authorization last October of 2022. It is a prodrug of the nucleoside derivative N4-hydroxycytidine. Inhibits replication of RNA viruses through viral error induction. Other viral drugs, okay, that has been given emergency use authorization was tocilizumab. It was given last April of 2020. It's a disease-modifying anti-rheumatic drug, first marketed as interleukin-6 blocking antibody through targeting the interleukin-6 receptors, and have proved its safety and effectiveness in therapy for rheumatoid arthritis. This given for hospitalized adults and pediatric patients 2 years of age and older who are receiving systemic corticosteroid and require supplemental oxygen, non-invasive and invasive mechanical ventilation, and even the extracorporeal membrane oxygenation or ECMO. Again, another drug that has been given EUA last November 19 of 2020 was baricitinib. Okay, it is given among hospitalized adults and children 2 years and older who require supplemental oxygen, non-invasive or invasive mechanical ventilation, or ECMO. It acts on the Janus kinases or JAK pathway inhibitor, and also a DMARDs or disease-modifying anti-rheumatic drug. JAK consists of a group of intracellular tyrosine kinases that transmit signals from cytokine or growth factor receptors interaction on the cellular membrane to influence cellular proteases, processes of hematopoiesis and immune cell function. Baricitinib is used for adults, okay? Especially it is used for adults for the management of rheumatoid arthritis and alopecia areata. Another drug that has been given EUA was tofacitinib. Okay, it is also a JAK pathway inhibitor and a DMARDs. It is mainly used for rheumatoid arthritis, psoriatic arthritis, ulcerative colitis, and ankylosing spondylitis among adults. And for the pediatric use of this drug was for the polyarticular coarse juvenile idiopathic arthritis. Then we have the sarilumab. It's a DMARDs. It's a human monoclonal antibody that binds to both soluble and membrane-bound interleukin-6 receptors. It is exclusively used for adults because for pedia, safety and efficacy is not yet established. It is classically used for rheumatoid arthritis, polymyalgia rheumatica. It was then used as an off-label, okay, for COVID-19 as of March 1 of 2023. It may be part of an investigational protocol for hospitalized adults with progressive or critical COVID-19 who have elevated markers for systemic inflammations when tocilizumab is not available. Then, of course, this one we have heard about a lot about it, the dexamethasone. This is a corticosteroid anti-inflammatory agent. It is a potent glucocorticoid with minimal to no mineralocorticoid activity. It decreases inflammation by suppressing migration of the polymorphonuclears and reducing capillary permeability. It is a systemic corticosteroid that improves clinical outcomes and reduces mortality in hospitalized patients with COVID-19 who require supplemental oxygen. And then the controversial ivermectin, okay, especially in the Philippines, okay, but though some countries have adopted, okay, ivermectin, so it is also included in the earlier slides. Okay. So ivermectin, though there is insufficient evidence for COVID-19 treatment, the US FDA approved prescription medication used to treat certain infections caused by internal and external parasites. That's what really it was licensed for. It's not authorized or approved by FDA for prevention or treatment of COVID-19. In the National Institute of Health COVID-19 treatment guidelines, okay, currently there is insufficient data to recommend ivermectin for the treatment of COVID-19. So it is still the best use for this drug is for the oral treatment of onchocerciasis and intestinal strongyloidiasis. Topical formulations are used to treat head lice and rosacea. Of course, it is more common as a veterinary application to prevent or treat internal and external parasitic infections in animals. So we will be covering antihelminthics, antifungals, and the drugs for COVID-19. So it is a little bit shorter than the part 2. Thus, okay, as Einstein said, because this is the last slides, we'll be ending now the lecture. Education is not learning, it's not learning of facts, but the training of the mind to think. So, thank you very much. Maraming salamat po for uh, viewing the three-part lecture series of the clinical therapeutics for antimicrobial. Hopefully, please click the thumbs up button and subscribe to my channel so that you'll be notified whenever there will be a new video, lecture videos that will be uploaded. Thank you very much. So we will be covering antihelmintics, antifungals, and the drugs for COVID-19. So it is a little bit shorter than the part 2.